Hello, everyone. Good evening. I'm Elizabeth Ford. I'm the office manager here for Spinal Diagnostics, and I just wanted to welcome you to the Advanced Pain Therapies webinar. It's brought to you in partnership with Spinal Diagnostics and Boston Scientific. This webinar will be presented by Dr. Jason Anderson and by Dr. Robert Heroes. I just want to take a moment to thank you all for being here this evening, taking time out of your day to listen to our providers and what they have to offer you for pain management. Please feel free to submit any questions that you have in the Q&A section at the bottom of the screen. That Q&A section is going to be anonymous, and so we want it to stay in there and not in the chat. We are going to answer all of the questions this evening that we can. Please feel free to submit them throughout the presentation. You do not have to wait until the end. We will be recording this webinar and we'll be placing it on our website at a future date. So just so you know, you can always reference it on our website later. So without further ado, Dr. Anderson, would you like to take it away?
Thanks, Liz. Hi, everyone. So tonight, we're going to talk about different treatment options for chronic pain, in particular, 3 different options. But before we do that, we're going to learn about chronic pain treatment options in general, what's traditionally been offered and what options have been out there. And then we're going to work our way towards newer options or options that are rapidly evolving and advancing that you may not be familiar with. And so we're also going to try to emphasize the fact that we want to pick the best treatment option for the right patient at the right time. So some of these options may be an option for one patient and not another. Or some of these options are actually a good option over time as we get older and different conditions evolve. So it's good to be familiar with all the different options over time. Next slide, please. So first of all, if you have chronic pain, is it preventing you from enjoying just basic house tasks or the ability to work and be productive, enjoy playing with children or grandchildren? All these things I hear on a regular basis in our office. Or outdoor activities such as walking, hiking, or golfing. I also hear about gardening a lot, and the ability to do arts, crafts, or music is really important. And then occasionally patients even confide that they want to be sexually active, but they can't because of their pain. And it's keeping them from enjoying life at the fullest. If you have chronic pain, you're probably familiar with some or all of these. And another aspect that isn't mentioned on here is, chronic pain also impacts emotions, and emotions impact pain, and it can be a vicious cycle back and forth with each other. They also cause you to be more exhausted and tired and need to sleep more. And so you're not getting out as often and enjoying friends and other people as often. Next slide. So, and if you've had pain, you've probably tried some of these options. Usually the first line is to try, Tylenol or ibuprofen or naproxen, which is Aleve. You've probably been offered physical therapy. And these truthfully are the first line options when anybody has pain. And most insurance companies now want you to try these options first. And then if you fail those options, then you can come and see us. Other options can include the TENS unit, which is like an electrical stimulation unit that you apply to pads on your shoulders or on your back or wherever you hurt, and they kind of distract from the pain. You may have tried opioid medications, although there's been a big backlash within the pain community to use those regularly and frequently for chronic pain. But you may have been on them back when we were highly encouraged to prescribe them. And so, but opioids being on them for a long period of time actually have a paradoxical effect and can actually make you more sensitive to normal pain stimulation. And so it actually makes things worse. You may have tried nerve blocks. You may have tried surgery. You may have tried drug pumps even, and not really had lasting good relief. They're just kind of workarounds. Or they may have worked great initially, and then there's no long-term benefit from them. Next slide. So when we talk about different types of pain, one classification system we can divide them into is mechanical or neuropathic. Mechanical means something occurs with a trigger. So every time you stand up straight or try to walk for a certain time or distance, you get pain down your legs or in your back. Or every time you bend forward, you get a certain type of pain. That's a mechanical type of pain. Whereas a neuropathic pain, it means nerve generated, and it's usually because the nerve is injured, chronically injured. They both can result in weakness, numbness, pins and needles, shooting, burning, stabbing pain. But a neuropathic pain typically is worse or is present all the time. Whereas mechanical pain, you may have relief in one position and not in another. And it's very characteristic. You do the same thing, you get the same kind of pain. Next slide. So next, we're going to talk about 3 different treatment options you may not have yet tried. The first one is radiofrequency ablation, which has been around for quite some time, but is being used frequently for, chronic pain related to joint pain frequently in the spine. Indirect decompression is another option we're going to talk about here shortly, and then spinal cord stimulation, which Dr. Hiros will speak about at the end. Next slide. So radiofrequency ablation is, first of all, radiofrequency ablation is an application of heat to a small area of nerve tissue so that the nerves no longer transmit pain signals. It's a minimally invasive outpatient procedure. It uses a small needle that we call probe. And really, the only difference between it and a regular needle is we can take out the stylet, which is the core of the needle, and we can put an electrode through it. It also has a tip that's exposed, and that's the only place that heat is transmitted. I think of it as a local microwave, because the actual tip of the needle typically doesn't get hot, but it causes the tissues around it to get hot. And it causes the nerve tissue to start dying off in that area. We consider using it if medication and steroid injections have failed to control the pain. Actually, in April of this year, Medicare has said that radiofrequency ablation is the treatment of choice for facet joint or pain from the lower joints in the back or neck or mid-back. It's the treatment of choice for that condition instead of steroid injections. Now, in order to justify doing radiofrequency ablation, we have to do 2 sets of diagnostic injections with local anesthetic or numbing medication to simulate what it would be like to deaden those little nerve branches. These little nerve branches are called medial branches, and they come off and they send the pain signals from these individual joints. And if the diagnostic injections give you excellent temporary relief, then we can go ahead and do the radiofrequency ablation procedure to make that more long lasting. The pain relief is typically anywhere from 6 months to 18 months and can be repeated when the nerves regenerate. So it's not a permanent solution, but it's a great solution. It maintains the normal mechanics of the back. And in the past, surgeons might have tried fusing for this issue, and they found out, 1, it didn't work that well long term, and 2, could create problems above the fusion or below the fusion, so which led to more surgeries and more fusions. So this allows your back to maintain its normal mechanics as they are, while also giving you significant pain relief. Radiofrequency ablation is also used to treat other areas of the body, including the hips and knees, although we don't currently offer that for that indication. but it does help for the back and neck. Next slide. And next, let's talk about the Vertiflex procedure. Next slide. First, before we talk about Vertiflex, it's important to know what type of condition it treats. And what is characteristic about this is it's a very mechanical type of symptom. Anytime you're standing or walking, you get pain, but you can get relief by leaning on a shopping cart or sitting down or even laying down in certain positions. I have some patients who actually sleep in their recliners before they come to see me because of this pain. This pain can also result in pain either in the low back, buttock area, or down in the legs. And it can cause sometimes very weird sensations or make you feel like you're going crazy, because one day you may feel more pain on the right side, let's say, and then the next day it hurts mostly on the left, or one day it hurts on both sides, and then one day it goes away. And part of that's the mechanical issues that are occurring in there, which I'll explain a little bit further. Now, patients often, when they come to see us, say that they have sciatica pain that's so severe they can't walk more than 100 feet without having to sit down. But as soon as they sit down, they can rest for a couple minutes and then get up and walk another 100 feet and then sit down. I have some patients who, in their garden, place multiple chairs around the garden so they can sit for the whenever they need to after being up for a short period of time. Other patients say that, their pain meds just don't work. Nothing seems to work, so they don't go out and do things. They can't walk very far. It's not fun to go out. Their balance is getting worse. Other patients say they can't get all the way around the store, or they fight their spouse or somebody else for the shopping cart, because that's the only way they're getting around the store, is by leaning on that shopping cart. Other patients complain that the medications that they have to take to control their pain just doesn't allow them to concentrate, or makes them feel spacey or out of it, or feel like they're in a fog. Especially medications like opioids can do that at times, or anticonvulsants like gabapentin or Lyrica that we use for nerve-generated pain, like numbness, tingling, burning, pins and needles. Those medications can make you feel out of it. Other patients say that, they tried cortisone injections to try to treat hip pain, and that didn't work. And they're told that maybe their pain's from their back. They don't know why they're there to see us, but they think that the pain's just in their hips. A lot of pain from the low back, in the spine in particular, is actually manifested in the lower limbs, in the hips, in the legs, in the thighs, and not in the back itself. So just because your pain is not in the low back doesn't mean that you don't have an issue that's originating from the low back. Also, patients will say that their legs feel numb, tingly, feel like their legs are going to go out. This pain also, it seems to have come on slowly and gradually over time, and is just getting worse and worse and worse. Next slide. So the condition that creates all these symptoms is called lumbar spinal stenosis. And it's a gradual narrowing of the space in the spine where the nerves pass through. And so if you can see on this model is matching the direction that the right-sided picture is. Here's the front of the spine. The back of the spine is here. These are the bumps that you feel in the middle of your back here. And in the middle here, we have the spinal canal. Again, this is the front of the spine up here, and the back of the spine here. And we have the spinal canal that runs through the middle. We also have holes on the side where the nerves exit, and on both sides. And then we have the central canal that runs through the middle. And I don't know how well you can see that, but there's this yellow in the middle, that's running in the spinal canal. Now you can have narrowing in the spinal canal either in the central canal, or where the holes are at where the nerves exit. both of those conditions can result in pain when you're standing and walking if the narrowing gets significant enough. And the way to get relief from that is by bending forward or sitting, which accomplishes the same thing. But you can see when the spine flexes forward that the vertebrae open up and allow more room, either at the hole where the nerve exits or in the central canal. And that's why patients with this condition get relief in those positions. When that pinching is occurring, though, patients can get numbness, tingling, weakness, or pain in one or both legs or lower back. And the other part of this is the spinal cord actually ends up here in the upper part of the low back and continues on as a bunch of nerves draping down through the central canal area. So every time you get up, you may pinch a different nerve that's running through that middle area. So, and then when you bend forward, it frees them all up and then clamps down, and it may clamp on a different nerve that's kind of freely floating. And that's why it may feel like one day it's in one leg and then the other, another leg, and move back and forth, or one time be in both legs or in no legs at all, or just in the low back. So the key thing is relief is experienced when bending forward slightly or sitting. So, and then the picture here on the left at the bottom shows a healthy central canal and opening where the nerves exit. And then the one on the right shows what happens when there's stenosis or narrowing, either in where the holes exit in the foramen or in the central canal. Next slide. So what I'm going to talk about next is the Vertiflex procedure for lumbar spinal stenosis. What you can see in the picture in the top right is before the Vertiflex procedure, the nerve is getting pinched there as it exits and it's bright red. And then after the Vertiflex procedure, there's a spacer device placed in the spine that basically props up the vertebrae there so that it's open like when somebody's bending forward or sitting, so that there's more room where the nerves exit or in the central canal. The Vertiflex procedure is a simple, minimally invasive treatment which can provide effective long-term relief. It's FDA approved. It requires a small incision, probably about the diameter of a nickel to a quarter size. It can be done in a same-day procedure. Typically, to do 2 levels would take about an hour. To do 1 level, probably about 30 to 40 minutes. It doesn't require any removal of bone or tissue. There is a speedy recovery time. Typically, at 2 weeks, we have you come back to have staples removed. For the 6 weeks following the procedure, we'd have you on bending, lifting, and twisting restrictions so that things can scar in. And then at 6 weeks, we would get you into a physical therapy program, but lift the restrictions. There's a very low risk of infection or complication, and it can provide long-term relief. And I think it's also important to know that more than 10,000 patients have been treated with this since 2016. So it was also being used in Europe for a while before it came to the United States. And then the East Coast, my East Coast colleagues and Los Angeles colleagues got access to this procedure at least a couple of years before I did, because I remember hearing about it from one of my colleagues that I trained with back East. And he told me I needed to start offering this for my patients. And then I had to hound the Vertiflex company until they would bring a rep here in the Northwest. Next slide. So what type of results can you get from this procedure? According to the research at 5 years, 9 out of 10 patients are satisfied with the Vertiflex procedure. And I've seen similar results within my own patients. I've treated close to 30 patients now, and I would say around 9 out of 10 have had excellent results from the procedure. There are patients that report a significant drop in the use of opioids. Since we don't do long-term opioid management, we don't really follow that much, but patients do report a significant drop in their pain. And a lot of patients that come to see us actually aren't on opioids to begin with. But they're happy to have the relief from this procedure. 81% of patients report improvement in physical function, and 75% report reduction in leg pain symptoms. Or 75% have a 75% reduction in leg pain symptoms. So here's a testimonial from Bill. He says, "I have no more leg pain, which was killing me before from my hip to my ankle. That is completely gone." And Gloria, who said that the day of her procedure, she went to visit the Butterfly Park in Scottsdale, and she felt happy and was able to walk around without any problems. What's really remarkable about this procedure is a lot of patients have almost immediate relief, which we don't get to see with a lot of the procedures that we do on a regular basis. Patients do get relief. It's just you don't get to see that immediate benefit always from procedures, which this one we do. Okay, so I'm going to kick it back to Liz, and thank you, everyone. I'll be available to answer questions at the end.
Thank you so much for that information, Dr. Anderson, on spinal stenosis and Vertiflex and pain options for our patients. I am going to kick it off to Dr. Robert Heroes. He is going to discuss some different pain management options, including spinal cord stimulation.
All right. Thanks, everyone. I appreciate the introduction and appreciate Dr. Anderson's great talk about his pain options. And, I really like one of the things that he said at the beginning, and that is really this is just about having options. No procedure is right for everybody. Nothing can help everybody. It just doesn't exist. And a lot of times patients come to us, both Dr. Anderson, myself, or Tyler, our PA, or Deborah, our nurse practitioner, and they say, my neighbor had an ablation, and, do you think that might help me? I mean, the snarky kind of easy answer is like, I don't know. We need to talk about your back pain because an ablation might help one person, but somebody with spinal stenosis, that's not going to help. And somebody with severe neuropathic leg pain after 5 back surgeries, the Vertiflex procedure is not going to help. So really, I think what Dr. Anderson and I have tried to do over the last 5 to 6 years is really develop our practice into something where we have lots of options for lots of different patients. And there's a great saying that I learned a few years ago that really encompasses that, and that's really that it's just about finding the right treatment for the right patient at the right time. So one of the areas that I'm really interested in is spinal cord stimulation. It's not for everybody. I'm always the first to say that, but for the right types of pain and the right patient, it can be a really great option. So let's dive in and talk a little bit more about that if we can go to the next slide. So spinal cord stimulation, really the best way to think about this is like a pacemaker for pain. I think we all know somebody who's had a pacemaker. A lot of patients already have pacemakers, or somebody in their family or a friend or a neighbor has a pacemaker. And it's a little implanted device that goes in the chest, a little battery like those the 3 silver batteries you see there in front of the iPad. And then wires connect into them and it beats the heart. Well, this is very similar. The only main difference is that the battery goes in the kind of the love handle area. Not that anyone out there has a love handle, but I know I do. And then the wires go into the spinal canal, and they kind of sit on the sac of fluid that surrounds the spinal cord. And the little electrical impulses help to reduce pain. They basically block pain, they modulate pain, they influence pain. Another way to think about it is like white noise. And it kind of drowns out the pain signals. Now, this is not a new therapy. It's been around for a long time, over 40 years. So since I was a very young person, it is FDA approved. There's excellent research behind it. It works well for the right indications. It's not a drug therapy. So that's one of the big benefits. There's several things I really like about that. And that's one about this therapy. And that's one of them. It's not drugs. It's not opiates. It doesn't have addiction or serious side effects. In fact, it can help reduce reliance on opiates and their side effects. So that's a really great thing. Another nice thing about spinal cord stimulation is that it is covered by most insurance plans, including Medicare and workers' comp. Again, it's proven. So for most indications that we have studied it for, it's kind of a known entity. There's not really a big question about it. Now, the technology has changed dramatically over those 40 years, not only to help patients do better, to make the therapy more effective and more tolerable, but also to open up the therapy to new indications. Now, of course, with any type of implanted medical device or any type of procedure, there are risks. There are risks with everything and anything we do in medicine. And to me, the issue is, do the risks outweigh the potential benefit? And that's not a decision that I make. That's a decision you make as the patient. And I think our job as physicians is not to tell you what to do. It's to listen to you, hear your story, try and figure out what the problem is, and then give you some options and educate you about the different options and help you make an informed decision. And again, for the right indication, this might be a thing that you're interested in. So let's go ahead to the next slide. So spinal cord stimulation is safe and effective. Again, there's lots of good research out there. Boston Scientific has done a lot of good research about this, showing excellent reduction in pain, improved outcomes in terms of function and activity tolerance, reduction in medication use. One study they did showed that 2 years after having a stimulator, pain scores went down dramatically, well over 50%. And that's a big thing. A lot of studies out there, a lot of products or devices are very promising in the first 6 months. And so when I look at a clinical research trial or an article in a journal, that's one of the things that we look at is, well, how long are they reporting data for here? If it's only 3 or 6 months, I don't know, that doesn't really tell us a lot. But going out to 2 years is actually fairly impressive. Next slide. So who can benefit from spinal cord stimulation? So again, right treatment for the right patient at the right time. So what kind of pain is this good for? Well, primarily good for neuropathic pain. Dr. Anderson talked about what neuropathic pain is. It's that constant nerve pain, usually is there no matter what you do, whether you're sitting or standing, very different from the type of pain he described for stenosis. This might be a burning, numb, tingling in the back, the buttocks, the waist, all the way down the legs. It might be just in part of the foot. It's a very common type of pain in what we call failed back surgery syndrome. And that just means somebody who's had back surgery and it either didn't work or unfortunately it made them worse, or if it did help, it helped for a while and then the pain came back. So that's failed back surgery syndrome. Neuropathy, whether it's a diabetic neuropathy or a neuropathy for no known reason, which is actually the most common type of neuropathy that we know about, or something called CRPS, complex regional pain syndrome. It used to be called RSD. That's a very weird, unique nerve pain syndrome that can be incredibly difficult to manage. So if you have a chronic nerve pain syndrome, like one of those that we've mentioned, and when we say the word chronic, we just mean it's been there a while, and really kind of by definition, that's like over 6 months, over 3 to 6 months. So if you've had this for a long time, you've been treated, you've had conservative therapy, you have pain in your back or your legs or your feet, it's not for mild pain. This is an implanted device in the spine. So this is not something that you consider for somebody who's had 3 weeks of mild pain. This is a bigger thing. So, we typically want to see a pain level of at least 5 or 6 to really justify something like this. And sometimes insurance companies will chime in and say, no, the pain's not bad enough. Easy for them to say, but still they do. They make the rules, unfortunately. It's not what we call a first line therapy. So this isn't when somebody comes to see me and they've had 2 years of back pain and they haven't done any therapy and they haven't tried exercise or stretching and they haven't done heat or they haven't taken ibuprofen. This isn't the kind of thing that we would be talking about. You definitely want to try simpler, safer, less invasive stuff first. Now, it says on this slide that it's sometimes an option when surgery is not a good option. Well, I would argue that even when surgery is an option, in certain cases, this might be a better option for the main reason that it's significantly less invasive. So when you compare a spinal cord stimulator to a traditional spine surgery, there is no question at all, it is significantly less invasive, risky, expensive, and it has a faster recovery. Those are 4 really good kind of check marks in its column compared to surgery. But That's not even the biggest check mark or the biggest pro. The biggest pro by far about a spinal cord stimulator is that you actually get to try it before you commit to it. So during a trial, and let's go to the next slide because I think the next slide is about the trial. No, you know what? Let's skip ahead. Can we skip ahead a couple slides? Because I know there's one about the trial. Perfect. Oh, back one. There we go. So a trial is a temporary version of the stimulator that we put in through a needle, and the wire goes from inside the back to outside. It plugs into an external battery, and there's a big bandage on your back. So it takes about 10 minutes to put this in. It's very, very minimally invasive, quick, and easy. There's no surgery involved. There's no incisions. There's no sutures. It's just done through a very small needle under light sedation, and you're out of there within an hour or so. You have that temporary trial for about a week, and then we take it out. And during that week, you get to kind of live with it and see what it's like. It's kind of like if you went to the car dealership and they gave you the keys for the car and said, take it for a week, then decide if you want it. So it's really nice, unique option to be able to try something before you decide. Now, insurance companies, again, they make the rules. It's their world and we just live in it. They will say that there has to be a 50% improvement. So if your pain is reduced by 50%. Now, there's a couple caveats to that. One is, how do you define that? How do you define pain? We can't stick a thermometer in your mouth and tell what pain level you have, or run a blood test and tell what pain level you have. It's subjective. So we're reliant on you as the patient to say, yeah, it helped a lot or it helped a little bit. And it can be difficult to put a number on that. And then the other question is, well, is it just a 50% reduction in your pain level? And the answer to that is no. Is it an improvement in your daily activities? Are you sleeping better? Are you walking better? Are you sleeping longer? Are you less irritable or grouchy or grumpy with your family because of your pain? Are you taking less pain medication? Honestly, for me, if it's a significant improvement in any one of those areas, that's a success. Now, the insurance companies say 50%. I'm sure no company that makes these devices, including Boston, wants to hear me say this, but I don't like 50%. My gut is that 50% is not good enough. I really like to see 60 to 80% improvement during a trial to feel good about the implant. And I do think that 60 to 80% improvement is a realistic goal. It's a realistic hope. Now, I say that in part because I want to go to the next point, is that this isn't a cure. This isn't a fix. It's not a miracle thing, okay? This is not going to give anybody 100.0% pain relief. For the population that this is a good option for, again, years of chronic nerve pain, has failed everything else, has had multiple back surgeries. We have to be really honest and upfront with ourselves and our patients and say that, what, being completely pain-free 100% all day, every day for the rest of your life may not be a reasonable option or a realistic option or a goal. But a 60 to 80% improvement is a very realistic option and goal for this therapy. And I think for most patients that are even thinking about this, when I put that out there, the response is, oh God, I'd kill for 60% relief. That would be amazing. So 60 to 80% improvement is what we're looking for from the trial. And then if the trial is successful, we would go on to have it put in. And having it implanted is a minor surgical procedure. Now, compared to traditional spine surgery, it is still significantly less invasive and risky. Now let's hop back a couple slides, Lee. So, how it works and what I'll experience with and personalized pain relief. Let's go to the next slide and I'll kind of talk about this stuff. So some types of spinal cord stimulation can be personalized just for you and your type of pain. And that can mean a lot of different things. That can mean that you've got pain in different parts of your body. Some people have pain in their feet. Some people have pain in their right leg and their buttocks. Some people it's the back, the buttocks, both legs all the way down, different areas. And most of the time, those different areas don't hurt the same amount. They can be very variable. And Boston Scientific in particular has some nice algorithms and programs that allow them to kind of target different areas simultaneously. And another way it can be personalized is there's different types of stimulation in terms of how you feel it or how your body senses it. There are types of stimulation that you do feel. That's called paresthesia, which kind of means a numb, tingly sensation. And that typically would be felt from the waist on down. Some people love how that feels. It can feel like a very soft, gentle, vibrating electrical massage. Frankly, other people don't like how it feels, and a lot of people are kind of in the middle. but their device can do that. It can do what's called paresthesia free, which means when it's running and working, you don't feel anything at all. It just runs in the background and you don't even know anything, except hopefully that you're having a lot less pain. And then the other nice thing about their device is you can actually do both of those at the same time. So if you like if you like that stimulation feeling in your legs, but you don't like it in your back, we can actually kind of target that stuff. So this is one of those examples of how the therapy has evolved over time, and really can target specific things for specific people. So was there one more slide, Lee, that we didn't have yet? I'm not sure. Nope, that's it. So, again, my take home message for spinal cord stimulation is it's for the right person at the right time with the right type of pain. And obviously, I don't know who's out there right now. I don't know what kind of pain that you do have. So frankly, this may not be a good option for you. And trust me, if it's not the right option for you, we don't want you to have it because you're not going to have a good outcome. So again, I think at our practice at Spinal Diagnostics, where Dr. Anderson and I and our two advanced practice providers, Tyler and Deborah, what we're really focused on is let's try to get to the source of your problem and try to identify what the pain source is, what's causing this issue, and then decide together what makes the most sense for you. What's the best option for you? And in partnership with companies like Boston Scientific, we have more options than ever. So we would be happy to see you and talk about those options. So please give us a call.
So we are going to do a little bit of Q&A. I saw that there is a couple of questions in that Q&A section. So I'm actually going to turn this over to one of our Boston partners. His name is Jimmy, and he's going to go over the questions with you guys. Thanks for submitting some.
Thanks, Liz. Yeah, the first question came in regarding leg pain and leg cramps, knowing that those are two different types of pain. First question would be, what would be your suggestion in ridding the horrible leg cramps that require muscle relaxers? And, is it better to just be inactive or just do the activity like gardening, painting, hiking, different things that you want to do, and just try to persevere through those afterwards? So two parts there.
Yeah, I'll just start, and Jason, by all means, if you have something to add, please do. But the thing that I think of immediately with that question is, well, it really depends on what those leg cramps are coming from, because there's a lot of different things that can cause cramping in the legs. Some people with stenosis report cramping. Some people with nerve pain report cramping. Cramping can be restless leg syndrome. Cramping can be from nutritional deficiencies and things like that. So it really depends on what the source of that problem is in terms of how we would go about treating it. On a side note, in general, maybe not specifically in terms of leg cramps, but the idea of, if I have pain, do I kind of push through it or lay back? I think you listen to your body is my general feeling. I'm not a big fan of pushing through pain because pain is sometimes trying to tell you something. So I think that's where you kind of, make sure you're working with your doctor to figure out what the source of the pain is, and then to talk about what can be done.
And I would agree with Rob. The only nuance I would put there is sometimes if you've been evaluated and you're told that you're not going to injure anything, then pushing through the pain may be the appropriate option. You can sometimes be too gun shy and really need to do the work to see advancement. But I would only do that not in the beginning. I would make sure you get a full evaluation and get a thumbs up before doing that. Like Rob, I would get evaluated first. And sometimes leg cramps can be nutritional, like Rob was talking about, low potassium, low magnesium, or low other things. Those respond well to that type of treatment. Other times it can indicate that there is a nerve injury, either ongoing or a permanent nerve injury, and there's weakness in that muscle, and it cramps because it's just overused and overworked. So, or it's an ongoing nerve injury and it needs to be treated. So I would get evaluated.
Great. That's perfect. The next question is directed towards spinal cord stim. And specifically, can you address whether this is appropriate for patients that have factor V?
Or factor V, yeah.
Yeah, factor V. Yeah, so that's a deficiency of a clotting thing. That's a clotting disorder. So it again, it goes back to the kind of pain you have. So if somebody has chronic neuropathic nerve pain of the back and the buttocks and the legs, and they have tried and failed other things, then they may be a good candidate for it. But with something like factor V, we definitely would work with the patient's primary care doctor or other specialists like a hematologist who manages that condition and find out if it's safe to do a minimally invasive procedure. Do they need to have some type of injection before or after? We would just work with the other specialists, but most of the time it's possible.
Great. Next question is directed towards disc replacement. If somebody was told that they needed multiple discs replaced, how would you approach that? Maybe through a workup, or what would be your response there?
You want to tackle that, Jason? Or you want me to?
Yeah, I mean, I would be happy to offer a second opinion. I would have to see the imaging, number one. We're not spine surgeons, so we usually try to help patients stay away from surgery if at all possible. There are certain situations where there's a fundamental instability in the spine, and if they're going to go in there and do surgery and weaken the spine structure, they may need to put in disc spacers or replace the discs because the discs are too far degenerated. And they're looking at the body from a structural standpoint and trying to keep a good foundation so the spine basically doesn't collapse even further. So I think it would be wise to get a second opinion. It never hurts to get a second opinion. I never discourage a patient from getting a second opinion. We can provide that, or you can go see another surgeon. But in general, we want to keep you away from having surgery that you possibly don't need, because I think we have more options available to us than sometimes a surgeon does. Whereas a surgeon may give a more definitive option, we can sometimes help patients with their goals and provide them different options.
Yeah, I think that's hitting the nail on the head. I would also add that it really depends what the goal of the surgery is and what it's trying to treat. A surgeon can be very effective at treating instability. Whether that's going to treat pain is a completely different story. And then when surgery is being done strictly for pain, then you have to ask the question, what kind of pain? Is it back pain or is it leg pain? Traditionally, surgery is much more beneficial for leg pain than it is for back pain. That said, when somebody gets a herniated disc and they get surgery because they've got pain going down their leg, the research would suggest that a few years later, you're probably going to be doing no better or worse, whether you have surgery or you have conservative treatment, including injections. So, like Dr. Anderson said, our goal is really to avoid surgery when at all possible. And acknowledging that, sometimes you do have to bite the bullet and sometimes there are things that have to be managed surgically. And we have pretty close relationships with not every spine surgeon in the city or in the state, because we frankly don't think all of them are as good as others. So if we're going to refer you to somebody, I think you can be fairly confident that it's somebody that we trust, we know, and is going to do a good job with it.
Great. Next question is general thoughts about acupuncture. I assume that's for the treatment of pain as well.
No reason not to try it. I mean, it's like any other treatment, in my opinion. And again, Jason, chime in, but I think acupuncture works great for some people for some kinds of pain. Doesn't work for everything or for everybody by any stretch. I think it's worth trying if your insurance company pays for it or you can afford it. The only thing I would say about acupuncture, I think if you're going to try it, you can't try it once. You should probably try it 4 to 6 times before you decide whether it's helping or not. It's not the kind of thing that you're just going to get instant results from most of the time.
Yeah, I would agree with Rob. I've had it done myself. I thought it was amazing when I had it done for relaxation, stress management results. So I'm not against it. I think it's worth trying if like Rob said, your insurance covers it or you can afford it. I kind of put it more in the physical therapy, chiropractic category. And if you're not getting relief with that, then we're probably the next option to come and see.
Great, thanks, Dr. Anderson. The next question is for Dr. Hero specifically. How long does spinal cord stimulation last?
Well, I guess there's two different ways of looking at that. How long does the therapy last, or how long does the device last? There is some traditional evidence that would suggest that over time, in certain cases, that the benefit can kind of drop down a little bit. If it does drop down, it tends to kind of stabilize. But trying to predict who is going to do well with something like a stimulator long term is an area of interest for us, and something that we are very passionate about, and we contribute to research. We're involved in clinical research. So that's something we're always looking at. Now, the device itself depends. There's a couple different kinds of devices. Some stimulators are what are called rechargeable, and others are non-rechargeable. A non-rechargeable battery means you put it in, you forget about it, it just runs, and you don't ever have to deal with it until the battery dies. And that's probably a 4 to 6 year window. And then when that dies, you have to replace it, and that's a very small, minor surgical procedure. Now, a non-rechargeable battery has the benefit of being a little smaller and lasting a lot longer. It's a little smaller because you don't have to pack as many battery cells in. And it lasts longer because you recharge it continuously. Now, that's the big benefit. So you're probably looking at about a 10-year life on that battery before it has to be replaced. The downside is it does have to be charged intermittently. And depending on the device and how long it's been in, that would influence how often it has to be charged. I personally tend to prefer the non-rechargeable because I think most patients would rather just not deal with it. But we always have that conversation and kind of figure out with you what's right for you.
Great, thank you. Next question is, are there non-pain med treatment options prior to a 2-level cervical disc replacement due to a cervical disc herniation, having numbness and tingling and electrical jolts down both arms?
Yes. Yeah, we would be happy to evaluate that. One of the issues that occurs with disc replacements or cervical spine surgery in general, or specifically, but it also happens in the low back, is once you start having surgery, it often leads to further surgery because it does change the mechanics of that of the spine. So the neck is a highly mobile area and is very susceptible to any restricted motion, especially above and below where the surgery was done. So it's not uncommon for patients to have issues then at adjacent segments. So for patients that develop new issues after having prior spine surgery, yes, we can help with evaluations, look to see whether perhaps epidural steroid injections are an option, or if those aren't working, potentially a spinal cord stimulator. Yeah, I mean, we have a variety of different treatment options. Sometimes patients are having more issues with joints after those. So radiofrequency ablation may be an option for them. But yes, we can evaluate you and see, and we have treatment options.
I would just kind of reiterate that, if there is something that is clearly compressing a nerve or the spinal cord, and there is weakness, clear weakness, significant numbness, loss of strength, loss of motor skills, coordination, that's the time when I think both Dr. Anderson and I say, we probably need to think about getting the surgeon involved here sooner rather than later. But aside from that, we just try to constantly remind people that surgery is by far the most invasive, highest risk way of dealing with these issues. So if there's not a pressing, urgent medical, need to operate, we would certainly encourage you to try everything else, because surgery is the one thing you can't undo. You can't go back on it.
Great. The last three are really specific in terms of, certain indications, almost really good case studies. I think that those would be kind of direct follow-ups for you guys that are more specific. So I will just leave these in the chat, and to the attendees who have placed those in there. I think a good follow-up would be probably deemed necessary for those. So Liz, I'll punt back to you here. Right around the 6:30 hour. Thank you so much.
Yeah. Thank you, Jimmy. So yeah, just to reiterate, the last three questions we have, we will definitely follow up with you independently. We'll have your contact information, and so that way you can get those answered. If you have additional questions for anybody out there that had more questions that they weren't able to submit, you can always email those to moreinfo@spinaldx.com. Our website is spinaldx.com. If you'd like to make a consultation to really vet out more questions that you may have and meet the providers in person, please do give us a call, 503-885-1515, obviously during operating hours between 8:30 and 5. I hope you guys enjoyed the presentation. Thank you so much for taking time out with Dr. Heroes and Dr. Anderson and Boston with us this evening. We look forward to treating you and taking care of you as our patients. Have a good evening.
Thank you,
Thanks, everyone.
everyone.